Good morning. My name is Dr. Saxena, and the purpose of this video is to demonstrate obstetric examination of a pregnant lady on a mannequin. Before we proceed with the actual examination, it is important to introduce yourself to the patient, explain briefly the process, seek her permission, and only then proceed to expose the patient. My name is Dr. Saxena, and today I am going to examine your abdomen. If it is okay with you, we'll proceed. It is important to have a chaperone at all times, especially for my male colleagues. This is not only for the protection of the women or the doctor, it also provides confidence to the lady that everything is above. The best is to ask the patient to expose herself, or the chaperone can help you with it. My male colleagues should not be fiddling around with the dress of the patient. You must ensure that the woman's abdomen is exposed right from the xiphisternum to the symphysis pubis. So we proceed with the inspection of the abdomen. The abdomen of a pregnant lady is generally distended by a gravid uterus, as evidenced by linea nigra. That is a darkly pigmented line seen running from the umbilicus to the symphysis pubis, and there will be stretch marks called stria gravidarum and stria albicans, especially on the lower abdomen. We also look for any scars, especially previous surgery like cesarean scars or appendectomy scar or any other surgical scar. If we find a scar, that needs to be described in detail. We look for fetal movements, and then lastly, we look for the flanks, whether the flanks are full or not. Before beginning with the palpation, it is important to ask the lady if she has any pain. Do you have any pain in the abdomen? No? Okay. Then you proceed with superficial palpation, where you palpate all the 9 quadrants for any tenderness. If there is no tenderness, then we proceed with the obstetric examination, estimation of clinical fundal height. This is done using the left hand, starting from the xiphisternum towards the umbilicus. Gently press in the midline to look for the firm resistance of the uterine fundus. This roughly gives us the gestational age. At 12 weeks period of gestation, uterus is just palpable above the symphysis pubis. Around 16 weeks period of gestation, it is found midway between the symphysis pubis and the umbilicus. Around 20 weeks of gestation, it will lie just below the umbilicus. 24 weeks, just above the umbilicus. The area between the umbilicus and the xiphisternum is divided into 3 equal parts. The junction of the lower and middle 1/3 gives a fundal height of almost 28 weeks. Junction of the middle and upper 1/3 corresponds to 32 weeks period of gestation. At 36 weeks period of gestation, the fundus lies at the xiphisternum, and beyond that, the fundus comes down. If I find the fundus below the xiphisternum and the flanks are full, the gestational age is around 38 weeks to 40 weeks. If I find that the flanks are not full, then this would correspond to 32 to 34 weeks period of gestation. We proceed with recording of the symphysis fundal height. For this, we first palpate the upper border of symphysis pubis. We put a measuring tape with the centimeter marking away from the examiner. Stretch out the measuring tape and again look for the fundal height. Once you find the fundal height, you reverse the tape and you can read the fundal height at 40 weeks. The symphysis-fundal height generally corresponds to the period of gestation from 20 weeks to 34 weeks period of gestation. Thereafter, it is usually around 7 to 38 centimeters. Next, we proceed with the Leopold's maneuvers. These are 4 maneuvers, also called the 4 obstetric grips. The purpose of these grips is to determine the lie, presentation, position and engagement of the fetus. The first maneuver is also called the fundal grip. It is done facing towards the face of the patient. We place both the hands on the fundus and we gently try to move to determine what is the fetal part underlying our hands. In a cephalic presentation, it will be the fetal buttocks which will be occupying the fundus, and these are described as a broad, soft, irregular mass occupying the fundus, suggestive of fetal breech. Second maneuver, also called the lateral grips, the right and the left lateral grips. Here, right and the left refers to the side of the patient. This maneuver is also done facing towards the face of the patient. We stabilize with the left hand and palpate with the right hand on the lateral side of the umbilicus. Then we reverse the process, stabilize with the right hand and palpate with the left hand. If we imagine the fetal back on the right side and fetal limbs on the left side, it is described as, in the left lateral grip, I can feel a smooth curved resistance suggestive of fetal back. In the left lateral grip, I can feel small irregular knob-like structures suggestive of fetal limbs. Third maneuver, also called the first pelvic grip or the Pollock's grip. This maneuver is also done facing towards the face of the patient. Here we place the ulnar border of the right hand just above the symphysis pubis, and we try and hold the lower pole of the uterus between the thumb and the fingers. We gently move it and try and palpate the structure which is occupying the lower pole of the uterus. In a cephalic presentation, it is usually the fetal head, and it is described as smooth, round, globular mass, and if it is moving side to side, it is ballotable. The fourth maneuver, also called the second pelvic grip, is done facing towards the feet of the patient. Fingers of both the hands are placed parallel to the inguinal ligament, and again we try and palpate the structures occupying the lower pole of the uterus. The fourth maneuver confirms the findings of the third grip, and it also tells us whether the fetus is engaged. During palpation, we also determine the amount of liquor surrounding the fetus. This is a subjective assessment. Thereafter, we proceed with auscultation. If we imagine the back of the fetus lying on the right side of the patient, the fetal heart is auscultated from the fetal back. Fetal heart sound is best heard on a line between the anterior superior iliac spine and the umbilicus, the spino-umbilical line, just above the fetal back. It is best heard using a Pinard's stethoscope, and if Pinard's is not available, the bell of the stethoscope can also be used to auscultate the fetal heart. On auscultation, we record the fetal heart for 1 minute, and that concludes our obstetric examination. At the end of the examination, always cover the patient back. Ask your chaperone to do it for you. Or you can ask the patient to do it herself. Thank the patient, tell her what your examination findings are, reassure her, and invite any questions.